So I'd like to introduce the first speaker. We have Dr. Muazzam Ali Akbar. Sir, if you could please unmute yourself and
Yeah,
start
right.
sharing your screen.
Yeah, okay. Am I visible now?
Yes, you are. You are.
Is it visible, madam?
It is. It is, sir.
Okay. Should I start now then?
You may start. Yes. All
Yeah,
the
right.
best. Thank you.
So good morning, all. At the outset, I would really like to thank AIOS Chairman Scientific Committee for giving us this opportunity. So with this morning cup of tea, we would like to have uh, a revision course in glaucoma. And my topic for today is Goldman applanation tonometry. So there's no financial disclosure. So why GAT, Goldman applanation tonometer? So as we know, the IOP is the only modifiable risk factor, and GAT still is the gold standard. It works on a modified invert fixed principle where pressure is equal to force applied by area. And when the prism diameter is 3.06 mm, it cancels all other forces except the important forces which we are considering here. So these are the important parts of the Goldman applanation tonometer. On the top, there's a biprism. Then you have a housing and you have a revolving knob to measure the pressure. So most importantly, what would be the slit lamp settings? So our slit lamp should be on the highest illumination, low magnification, the cobalt blue filter should be on, and the angle between illumination arm and the eyepiece should be around 40 to 60 degrees. What are the patient's factor? We have to make sure that patient is relaxed and comfortable, and there should be no breath holding. And if at all any necktie or anything is there, we have to loosen it. Now about the procedure as such, so we have to explain the procedure to the patient. We have to tell them that it is safe and painless. A drop of topical anesthetics is put into the lower cul-de-sac. Stain the tear film with fluorescein strip. Wipe off excess of the tear. The proper positioning is very important. So we have to make sure that the chin rest, head rest, and the lateral canthi alignment on the slit lamp, they all should be at proper place. So this is how we take it. So the prism should actually touch the central cornea. And when we touch this, this is how the prism should actually put onto the central cornea. Only touch it, not press too much. So this is our the 0 point where we have to catch the pressure. So the two semicircles, the inner margin of them should be touching each other, just touching each other. These are the incorrect positions, and to make it correct, we have to either move the joystick up or down, left or right, or the pressure measuring knob, we have to go forward or come back so as to align it correctly as in this picture. So some important tips while taking this pressure is important, like we have to wipe off excess of tear and stain with the help of cotton or tissue paper. If at all there is a need to separate the eyelid to put the biprism properly onto the cornea, we have to separate the eyelid with our index finger and thumb. But mind you, we have to press over the orbital rim and not on the globe. Now, when we want to take this IOP, we have to slide the slit lamp by looking from the sideway till it reaches near the cornea. And then one has to switch to the eyepiece. Touch the cornea gently with only forward tilt of the joystick. So as with any procedure, this procedure, though it is gold standard, it has some contraindication and limitations. So one should not do it on open globe injury or any kind of injury or corneal ulcer and infection cases. Again, this cannot be taken on a supine position and patient where you have irregular cornea, corneal scar or opacity, and also over contact lenses. Now we must know also about the errors, and the most important of them are corneal thickness. So when you have a thin cornea, this actually underestimates, and when it has a thick cornea, it overestimates the IOP. When the astigmatism is more than 3 or 4 diopter, then in case of with the rule astigmatism, it underestimates the IOP. And against the rule astigmatism, it actually overestimates. Now, if you have a lot of tear film and stain, you will have a thick mire, and it will actually overestimate the IOP, where in case you have a very thin mire, it will actually underestimate. So in case you have a thick mire, you have to wipe out excess of the stain or tear film. And if you have a thin mire, what you can do, you can ask the patient to blink a couple of times and again recheck. If not, you can also put little more of fluorescein stain into the eye. Now, the antisepsis part of the pie prism is very important, and the most common and convenient of them is alcohol wipes, but one can alternatively use 3% hydrogen peroxide and also 70% isopropyl alcohol. Mind you, once we do it, we have to let it dry for at least a couple of minutes. Otherwise, it can cause corneal damage. Now, calibration is also very, very important, and we have to do every month or every alternate month. Otherwise, there's a chance of faulty result. So the calibration rod and reference block, it is actually provided with the machine. How we do it? So we have to check the rod. There are 5 markings on the rod. Central is 0. On either side, 20 millimeter of mercury. And farther ahead, on either side, it is 60 millimeter of mercury. So what we do, with a small video, I would like to explain this. So this is the calibration rod, and these are the 60 millimeter marking and 20 millimeter marking. So this reference block is actually set here. It is with the 20 millimeter of mercury, and that is how it is actually put into the box. And then you see when it is moving on the 2 mark, it is actually, you just see the prism, it will move back. So when it is, the calibration should be such that it should not go beyond the 1 mark. So this is actually 2 corresponds to 20, 1 corresponds to 10. So it should be actually lie between 18 and 22. So if that is so, the calibration is good. If it is going beyond 18 or 22, the calibration is not good. And we have to send this to the service people who will do it from their end. So my take home message would be, before taking this IOP, we have to have a comfortable positioning of the patient and doctor. The procedure should be explained well to the patient. We must not do it into the infective cases or in the injury cases, and a periodic calibration of the Goldman applanation tonometer is a must to have an accurate result. Thank you. Thanks a lot.
Thank you, Dr. Muazzam Ali Akbar, for your wonderful presentation. Next speaker is myself. Yeah, my PowerPoint is visible.
Yes, sir, it's visible.
Okay. So, very good morning to all of you. The optic nerve is the defining pathological feature of glaucoma, and accurate clinical evaluation of the optic nerve head remains a critical part of glaucoma management. In this presentation, I would be discussing the optic disc under the following headings. The first and the foremost thing one should do when we start examining the optic disc is to determine the actual size of the optic disc. For this, one needs to carefully delineate the scleral ring. The scleral ring is a wide circular band of tissue that separates the intrapapillary region of the optic nerve head from the peripapillary region. And once the scleral ring has been defined, the disc margin is determined as the internal edge of the scleral ring. Now the disc diameters can be measured in both vertical and horizontal meridia. The direct ophthalmoscope has been the most popular instrument in the clinical examination of the optic disc. The 5-degree aperture of the Welch-Allen ophthalmoscope produces a circular spot of light having a diameter of 1.5 millimeters and an area of 1.77 millimeters square, which has an area of about 2.1 millimeters square to 2.7 millimeters square. Now, this circular spot of light may be aligned over the optic disc or adjacent to the optic disc, and then the size of the optic disc is compared to the size of the spot of light. If the optic disc is smaller than the spot of light, the disc is labeled as small, and if the optic disc is 1.5 times larger than the spot of light, the disc is labeled as large. Slit lamp biomicroscopy with handheld lenses offers tremendous advantages in evaluating the fine details of the optic disc. We commonly use high plus diopter lenses in our daily routine clinical practice. The correction factors should be multiplied by the measured aperture height value to determine the actual disc diameters. Average vertical diameter is about 1.8 millimeters and average horizontal diameter is about 1.7 millimeters. The size of the optic cup also varies with the size of the optic disc. This is an average sized optic disc having a vertical diameter of about 1.9 millimeters. This is a small sized optic disc having a vertical diameter of 1.4 millimeters. And this is a large sized optic disc having a vertical diameter of about 2.4 millimeters. So from these photographs, it can easily be appreciated that with the increase in size of the optic disc, the size of the optic cup also increases proportionally. So initially, it is very important to determine the size of the optic disc. A small optic discs have an average vertical diameter of less than 1.5 millimeters, and large optic discs have an average vertical diameter of more than 2.2 millimeters. The optic disc has a slightly vertically oval form, the vertical diameter being about 7 to 10% larger than the horizontal diameter. The shape of the optic disc is not correlated with age, gender, laterality of eye, body weight, and height. An abnormal optic disc shape is significantly correlated with increased corneal astigmatism and amblyopia, and glaucoma susceptibility is independent of the shape of the optic nerve head. As I mentioned earlier, that the larger the optic disc, the larger is the optic cup, and vice versa. In very small optic discs, cupping normally does not occur. In small optic discs with small cups or absent cups, glaucomatous abnormalities are seen in the parapapillary region. In case of myopic optic discs or in eyes with shallow cups, assessment of the location of kinking or the bending of vessels can be helpful in determination of the cup margin. In normal eyes, the shape of the optic cup is horizontally oval, the horizontal diameter being about 8% larger than the vertical diameter. It has also been found that larger the optic cup, the deeper it is, and the deeper the optic cup, the smaller is the parapapillary atrophy. Because of the vertically oval form of the optic disc and horizontally oval form of the optic cup, the cup disc ratios are significantly larger horizontally than vertically. The size of the optic cup should be assessed in relation to the size of the optic disc, and one should carefully assess whether the cup size is appropriate for the disc size. If there is a difference of cup disc ratio of more than equal to 0.2 between the two eyes in either axis, horizontal or vertical, the cups are said to be asymmetrical. But one important criterion needs to be fulfilled before labeling the cups asymmetrical, and that is the optic discs of both the eyes should be of equal size. The neuroretinal rim is one of the main targets in the clinical evaluation of the optic nerve. the neuroretinal rim size demonstrates considerably high inter-individual variability, and it is significantly correlated with optic disc area. Larger the optic disc, larger is the rim area. The neuroretinal rim area shows a characteristic configuration. It is based on the vertically oval shape of the optic disc and horizontally oval shape of the optic cup. The neuroretinal rim is usually the broadest in the inferior disc region, followed by the superior disc region, the nasal disc region, and finally the temporal disc region. This is the classical Eysenck rule that we all know of, a term that was coined by Werner. So when one starts to examine the neuroretinal rim, three questions need to be addressed. First, whether Eysenck rule is maintained or not. Second, where is the smallest NR width? And finally, whether NR loss is focal or diffuse. There is a loss of neuroretinal rim tissue with advancement in cupping, and hence the cup enlarges. The loss of neuroretinal rim tissue can affect only one region of the optic disc, either superior or inferior, or both regions of the optic disc, both superior as well as inferior. So cup enlargement can be unipolar when only one disc region is affected, as evident in this first photograph, where the cup is enlarged predominantly in the inferior direction. In the second photograph, the cup has enlarged in both directions, superiorly as well as inferiorly. So here the cup enlargement is bipolar. These photographs show advanced glaucomatous cupping with diffuse loss of neuroretinal rim tissue. As a result, the cup has enlarged in all directions. And another way to say is that the cup disc ratio has increased both horizontally as well as vertically. Neuroretinal rim tissue loss can be focal and localized, which is commonly known as notching. The first photograph shows a superior notch, and the second photograph shows an inferior temporal notch. Increasing pallor of the optic disc, and especially of the neuroretinal rim, is a typical sign of optic nerve damage. The increase in pallor of the neuroretinal rim may be more marked in eyes with non-glaucomatous optic neuropathy than in eyes with glaucoma. Here, the optic disc is grossly pale with pallor of the neuroretinal rim. At first look, one can easily label this disc to be glaucomatous, but when we carefully observe the location of kinking of the vessels, the cup is not found to be enlarged in proportion to the rim pallor. So whenever one comes across such optic discs where pallor is more than cupping, one should always think of non-glaucomatous etiology. The retinal nerve fibers, or better, the retinal nerve fiber bundles, are detectable as bright and fine striations in the inner retinal layer, fanning off the optic disc to the retinal periphery. These are categorized into the following 5 important bundles. In normal eyes, the visibility of the retinal nerve fiber layer is regionally unevenly distributed. Now, dividing the fundus into 8 regions, the nerve fiber bundles are most visible in the temporal inferior. In the temporal inferior sector, followed by the temporal superior sector, the nasal superior region, and finally the nasal inferior sector. These bundles are least visible in the superior, inferior, temporal horizontal, and nasal horizontal areas. Again, when Rnfl is evaluated, 2 questions need to be addressed again. First, are there any localized Rnfl defects? And second, is there an overall decrease in Rnfl visibility? Rnfl defects can occur in a diffuse way or in the form of localized defects such as slit-like defects or wedge-shaped defects. However, one should be aware that the Rnfl defects are not pathognomonic of glaucoma. This is a typical example of a slit-shaped Rnfl defect. This is an example of a wedge-shaped defect that is classically seen in glaucoma. Here, I would like to emphasize that the retinal nerve fiber layer should always be examined under red-free light. It is under the red-free light that these defects become more easily distinguishable. This is a classical example of a wedge-shaped defect inferotemporally. One important feature of Rnfl defect is that if a large retinal vessel runs across this area, it becomes more clear and sharply detectable. The main difference between a wedge-shaped defect and a slit-shaped defect is that a wedge-shaped defect runs towards the optic disc and touches the optic disc margin. In contrast, a slit-shaped defect never runs towards the optic disc and never touches the optic disc margin. This is a typical example of a diffuse Rnfl loss. The diffuse Rnfl loss is more difficult to detect than a localized defect. but it is always very helpful to evaluate whether the large retinal vessels are clearly and sharply detectable. Parapapillary chororetinal atrophy has been divided into a central beta zone and a peripheral alpha zone. The peripheral alpha zone is characterized by an irregular hyperpigmentation and hypopigmentation and intermittent thinning of the chororetinal tissue layer. Beta zone is characterized by marked atrophy of the retinal pigment epithelium and choriocapillaries, resulting in good visibility of large choroidal vessels and sclera. Psychophysically, beta zone corresponds to an absolute scotoma and an alpha zone to a relative scotoma. This is an advanced glaucoma with parapapillary atrophy. I suppose we can all appreciate a halo of parapapillary atrophy all around the optic disc. So this is the beta zone. Now let us try to focus on this crescent-shaped area of irregular pigmentation. So this is the alpha zone. Alpha zone can be found in normal eyes as well, whereas beta zone is more commonly seen in glaucomatous eyes. This is another example of parapapillary atrophy. Coming to the vascular signs can be disc hemorrhages, bionetting, bearing of circumlinear vessels, overpass vessels, and nasalization of vessels. Splinter-shaped hemorrhages or flame-shaped hemorrhages, also called as branch hemorrhages at the border of the optic disc, are a hallmark of glaucomatous optic nerve atrophy. They are seen in about 4 to 7% of eyes with glaucoma, and in early glaucoma, they are usually located in the inferotemporal or superiotemporal disc regions. They are associated with localized Rnfl defects, inara notches, and circumscribed perimetrical loss, and they indicate progression. These hemorrhages are visible for about 8 days to 12 weeks after the initial bleeding. Detection of these hemorrhages requires careful examination because they can occur anywhere on the disc and also vary in size. What is bionetting of vessels? Now, with advancement of cupping, the vessels emerge from the floor of the cup, then ascend up the steep wall of the cup under the overhanging wall of the cup, at which time they are not visible to the observer, and then emerge again at the disc margin, making a sharp bend, and that resembles the bayonet of a rifle. Circumlinear vessels are small branches arising from the retinal vessels seen in about 50% of normal eyes. With the enlargement of cup, the circumlinear vessel remains in its position and the cup margin recedes further. So, and as a result, an area of pallor appears between the cup margin and these vessels. As the neuroretinal rim narrows, the loss of nerve tissue leaves this vessel isolated or bared. So acquired bearing of circumlinear vessels is an early sign of rim thinning and thus diagnostic of glaucoma. Normally, the vessels run over the surface of the optic disc and the neuroretinal rim and then come out. A loss of neuroretinal rim takes away their posterior support and they appear to hang over the optic disc and bridging the optic cup. So this is also known as overpass cupping. Normally, the retinal vessels enter the eye along the nasal border of the optic disc and their branches run along the margins of the disc and cup and then emerge somewhat temporally. With enlargement of the optic cup, the major vessels may show a further nasal shift. To summarize, the vascular signs can be hemorrhages at disc margin, bionetting of vessels, bearing of circumlinear vessels, and overpass cupping. These 4 vascular signs are specific for glaucoma. Diffuse and focal narrowing of the retinal vessels have been described for both glaucomatous as well as non-glaucomatous optic neuropathies. The generalized and localized narrowing of retinal vessels is typical of optic nerve damage, but not characteristic of glaucoma. Exposure of the laminar tissue occurs secondary to loss of neural tissue. The pores of the lamina cribrosa can also be seen in normal eyes as well. In normal eyes, these pores are usually round in shape, but in glaucoma, as cupping increases, these pores become more slit-shaped. So appearance of these slit-shaped pores on the lamina cribrosa is known as laminar dot sign, and this sign is not specific for glaucoma. Optic nerve head changes in glaucoma can be classified in many ways. Changes can be structural, contour, and color changes. Changes can also be quantitative or qualitative. Changes can also be categorized into intrapapillary and papillary regions. So finally, when one starts examining the optic disc, one should remember the 5 R's or the 5 rules. If you remember these 5 R's, you're not going to miss anything. So what are these 5 R's? First, observe the scleral ring to identify the limits of the optic disc and its size. Second, identify the size of the neuroretinal rim. Third, examine the retinal nerve fiber layer. Fourth, examine the region of the parapapillary atrophy. And finally, look for retinal and optic disc hemorrhages. To conclude, I would like to say that careful assessment of the optic nerve head is probably still the best way of diagnosing early glaucoma. Thank you for your patient hearing. Next, I would like to invite Dr. Palaniswamy Krishnamurthy to enlighten us on practical guide to interpret visual fields. Yeah, please share your screen.
Is the slides visible?
Not now.
It's not visible?
Not yet.
Is it visible now?
No.
Not visible?
No. I think in the meantime, Dr. Lippi can can do the presentation.
Yeah, thank you.
Yeah, you can start.
Yeah, right. So my topic is I'm Dr. Lippi, and I was associated with Arvind Eye Care System for some years. Now I am practicing in Durg, Chhattisgarh. The topic for today is optical coherence tomography in glaucoma. No financial disclosures here. There are many varied tests to diagnose glaucoma and predict its progression. Some of them have been dealt with the past two speakers, and visual fields will be dealt by Dr. Palaniswamy. What we need to remember is glaucoma is a clinically diagnosed disease based on a structural and functional examination. Anterior segment OCT is mainly to feature the angle anatomy. This has helped in understanding the use of early cataract surgery in narrow angle glaucomas. Also, a rather recent use of OCT has been in morphology of bleb, which helps to manage the impending bleb failure. Posterior segment OCT is the prime coverage of the presentation. ONH, peripapillary nerve fiber layer, or Rnfl, and macular thickness are the three components used in glaucoma. We will be dealing with each section-wise. So the first component is ONH, optic nerve head analysis. This is a classical printout of Zeiss OCT. In this, we can find the optic nerve head analysis results outlined as disc area, cup area, rim area, CDR. It is 0.85 in this case, which is also reflected in the infrared image. So it's a big cup. Corresponding spectralis, it's optoview. So corresponding optoview RT view picture of ONH analysis. I won't be able to cover all three types of OCT, so I'll be just showing some random pics. Second component is Rnfl analysis. We all know that healthy Rnfl is thicker at superior and inferior quadrants. Now, what we need to recall or remember is that diameter of 3.45 millimeter is the area around the optic nerve head where the Rnfl analysis is done. So this has got fallacies of its own. This is Rnfl thickness average analysis, various zones. Second zone is TS-NIT with age-matched normative. Third is TS-NIT overlap of two eyes. Fifth is data table, and seventh is percentile color coding. This is known to us, percentile color coding. 1% of normals, they fall within the red band. So this is considered outside normal limits for most of the population, but we should remember that 1% do fall within this red zone. This is again the corresponding Rnfl analysis on another machine, that is Heidelberg Spectralis. This is HFA visual fields and Cirrus Rnfl combined report. So just for example, like here, if it's a case which is having inferior scotomas, corresponding superior Rnfl defect can be seen in all this thickness map and thickness deviation map and in the curve in the graph. Similarly, in the left eye, we are finding it's a sort of advanced or moderate glaucoma with lots of scotomas, and we find red zones in the OCT also. This is Rnfl analysis with the spectralis OCT. So there are minor differences between all these three types of OCT. So nothing major. Optic disc photograph, if we have, this is the right eye, which is having some superior rim thinning. We are getting the characteristic inferior scotoma. And in this, we are finding so many red zones. So in the superior, because there's superior thinning, so superior is red, and also temporal, and some part of inferior is also in the red zone. OS, on the other hand, the left eye, the disc, optic disc looks to be fairly normal, and we are getting visual fields and the OCT to be normal. The third component is macular thickness analysis. So GCC, we know that it is composed of NFL plus GCL plus IPL. So this becomes thinner in the glaucomatous eyes. We are able to detect glaucoma at an early stage with the GCC OCT. Normal macular thickness is something like this. This is a Zeiss printout. And in the case of glaucoma, the Rnfl is of course thinned out, so the curve goes into the red zone. Where do we have this use of GCC? We see many practical examples. So this is an example of normal Rnfl thickness, wherein around the optic nerve, it is all warm colors, yellow and red. The curve is also in the green zone. Rnfl thickness appears normal. But when we see the significance map of GCC, then there is a red zone around fovea. That is implying that there is loss of ganglion cells. So this might be glaucoma. This is where GCC helps us. This is the ganglion cell OU analysis report. This is how the film looks like. Progression analysis is the fourth component where OCT is used increasingly these days. This is in early and moderate glaucomas, not to be in severe glaucomas. So these are the two baseline reports, and the signal strength we need to check on all visits, of course. We are finding that the warmer colors are disappearing in the later stages, and in the significance map, we are getting some red zone. So this slope also, this gets plotted on its own, inferior Rnfl thickness slope. We are finding that it is declining and the rate of change is minus 6.01. Also note that CDR is almost stable. The rate of change here is 0.00. So this might be progression. Another example of progression, here we are finding some thinning of the inferior rim. This is an artifact, the yellow one is an artifact. And perimetry, when we do, one has been unreliable. This is 2016 reliable. And we are, when we do this OCT, we are finding that the thickness of Rnfl, it is slightly decreasing from 64 to 50 micron. So this again might be progression. We need to wait with other clinical parameters. This is the pre-perimetric glaucoma where OCT, again, it is useful. This might be labeled as a big cup, physiological cup, but we are finding here some hemorrhage. So this may be due to systemic factors. We don't know what's the cause of it. SAP is normal. When we see OCT, we are finding some yellow on here, and also the Rnfl graph, the curve, it is not really into the green, it's going towards yellow. So again, we need to be cautious with this size. So this is the use of OCT. Again, we have to have some caution in using any machine, including OCT. So what are the factors which we need to give importance to? Signal strength for different machine, it is different. Acquisition fault, ring not concentric with optic disc, or if the patient blinks, hazy media, like PCO commonly, or even early to moderate cataract, small pupils, segmentation error like PVD. So this can all give some false readings. So this is one interesting example. Now this is the myopic disc, slightly myopic disc of the same patient. Patient's forehead was a little away from the band, or he had some head tilt maybe. And so we are getting here, there is no RNFL. Here the RNFL has started appearing, and here suddenly it appears nicely. So we need to have correct positioning of the patient. About the signal strength, we all know 5 to 10 signal strength, it is increasing, and we are getting RNFL size increase, thickness increase from 97 microns to 118 microns. Scan location and eye movements, that does affect results. Poorly centered, if it is too inferior, the circle is too inferior, we are getting inferior RNFL loss, and similarly superior RNFL loss. Then we have the effect of blink. So error due to blink, if missing data represented in black suddenly, and we are getting red in the deviation map. Artifacts, effect of floaters. This is the PVD, which is not within the measuring circle. So this is not affecting the OCT. This is the Heidelberg spectralis OCT. When this PVD, vitreous floater, goes and sits on the disc, then it affects the center of a scan. There is loss of data, which represents the nasal NFL. So we need to be careful in case of PVDs. Again, the normal superior and inferior RNFL bundles look something like this. There is something like an entity like physiologically split RNFL bundle. So if that is there, then that may be interpreted as apparent RNFL thinning. Red disease and green disease, we have read on this. Red disease is false positive. Thinner RNFL of a high myope does not conform to the limits identified by a normative database, and so everything falls in red. Myopes, again, we say that ganglion cell analysis, that is more of a OCT, more of a data which we should rely on rather than the RNFL thinning. Sometimes it may be falsely red, but most times ganglion cell analysis, OCT is the choice in myopes. Large vitreous floater in the case of left eye. These are the two vitreous floaters. So these are obscuring the signal within the measuring circle, and this is influencing the RNFL thickness in case of left eye. Again, I want you to note here the irregular shape of the optic nerve, which is not there in right eye, and also the segmentation error. So see, these blood vessels are discontinuous. So what this indicates? Motion artifact. Patient has moved his or her eye. Green disease, red disease का just opposite है ये. So what is green disease? This is false negative. So there is glaucoma, but the OCT shows all green and white. Green is not always clean. So left eye is normal, all warmer colors here. First, let's see this optic disc picture rather. So in this, there is some superior rim thinning. Perimetry is done. There are some inferior scotomas. So OCT has been advised, and what we get is some superior RNFL thinning. But just see here, it's all showing green and white, even though it is 1155 micron in the superior quadrant as compared to 156 in inferior, and the left eye is 159 and 169. But it is not showing glaucoma in the superior, or the superior RNFL thinning is not being shown here. So we need to be cautious about this green disease also. So all in all, to conclude, man is a sloppy but brilliant thinker. Machines, they are fast, accurate, but stupid. So we need to have a synergy of both to get the best results. Thank you, AIOS, and thank you all co-instructors and chief instructor, Dr. Shiraz Ali sir. Thank you.
Thank you, Dr. Lipi Chakravarti, for the wonderful presentation. So Dr. Palni, you are ready?
Yeah, your screen sharing is visible, Palani sir. It is showing you have started screen sharing.
Unmute yourself.
You can mail also, sir. Palani Swami sir, you can mail your presentation to anyone, Shiraz sir or me. Yeah, it has come.
Is it visible now?
It was just visible half minute back, sir. Now it is all black. Yeah, it's visible. It's visible.
Yeah, it's visible now.
Yeah. Yeah, full screen is done. Fine, sir.
Am I audible?
Yeah, you're audible, sir. Screen is visible.
Am I audible?
Yes,
Yeah,
yes.
you are audible.
Good morning. I'd like to thank the scientific committee for having given me this opportunity. My talk today is Practical Guide to Interpret Visual Fields. I have no financial interest in any of the products discussed in this presentation. So visual field is that area of space where objects are simultaneously visible to the steadily fixating eye. And our visual field is in the shape of a hill. So the hill has two components, the height and the contour. So all the perimeters try to measure this hill. The Humphreys field analyzer is an automated static perimetry. It has a uniformly illuminated bowl in which white light of varying intensity is projected at different points, and we try to find out the threshold. Now, the threshold is the intensity of stimulus, which has a 50% probability of being detected. Fovea has the highest threshold. We have multiple programs like the 30-2, in which the points are 6 degrees apart, 24-2, after the edge points are removed again, and we have the 10-2, which is the central 10 degrees, in which the points are 2 degrees apart, and the Macular program, which has the central 16 degrees of the 10-2. In this, the points are 2 degrees apart. We have multiple thresholding strategies. Initially, we had the full threshold. It took nearly 14 minutes. Now, with the time, in order to reduce the time, we have different algorithms such as the FastPack and the CETA. Coming to the interpretation, this is how the visual field printout looks like, and there are multiple zones. So we'll take each zone at a time. First is the zone 1, which has all the patient details. With regards to the patient name, the patient's name has to be entered correctly, initial, the correct program, stimulus size, the correct pupil diameter, visual acuity, refraction. Most importantly, the age has to be corrected, entered properly, because the patient's values are compared against the age-related normal. Zone 2 is the reliability indices. In this, this tells us whether a field is reliable or not. So we have the foveal threshold. The foveal threshold should always be compared with the visual acuity. Then we have the false positives and the false negatives. They need to be less than 20%. If they are more, it's an unreliable field and we get a XX symbol. Occasionally, the machine will also give a stimulus to the blind spot. And if the patient responds, that becomes a fixation loss. Anything more than 20% is poor reliability, or it can also be seen in advanced glaucoma. Right at the bottom, we have the gaze tracker where it tracks the eye movement. An upward movement means the eye moved up, downward was a blink. So in case we have a skyscraper-like gaze tracking graph, the reliability is poor. Next is the raw data and the grayscale. Raw data is the threshold sensitivity at each and every point in decibels. This is what the patient has done. Grayscale should never be used for interpretation. It's only to educate the patient and to identify false negatives or false positives. False negative is when the patient was initially attentive, and as the test progressed, he became inattentive. So you have a typical clover leaf pattern. White scotomas are seen in false positives. The patient has given a response when there was probably no stimulus. Zone 5 and zone 6, that is total deviation and pattern deviation, are the most important graphs of the visual field. In total deviation, there is point by point difference. That is, the values of the patient are compared with that of the age-related normal. So this reveals a generalized depression. So in this, we need to look at the numerical data as well as the probability chart. The probability values indicate the significance of the defect. Lower the P, greater the clinical significance. This is the normal hill of vision, and this is what a generalized depression. It usually is seen in maybe in case the patient has cataract. Next comes the pattern deviation. Pattern deviation, it reveals focal defects after adjusting the height of the hill of the vision. This is done using the 7th best point. So this confirms a scotoma as is shown between these two. Here the pattern deviation shows a lot of depressed points, but if the total deviation shows a lot of depressed points, pattern deviation shows a depressed points only in the superior field. So this is how it is. A localized defect can be missed, but if the height is reduced, it becomes very prominent. Next comes the global indices. We have the mean deviation, pattern deviation, and the visual field index. In case we do a full threshold, we also have the short-term fluctuation and the corrected pattern standard deviation. So mean deviation indicates the overall deviation of the field from normal. So it can either be an elevated field or a depressed field. Elevated fields at times can also be because of a trigger happy patient. So what this does is all the patient's values are added up and divided by the number of points. The same thing is done for the normal database and it is compared. The difference gives us the mean deviation. Pattern deviation is the resemblance of a patient's field to the shape of the hill of vision. It has a positive sign. A low PSD means it's a normal shape of hill. A high PSD means the shape of the hill is disturbed. Visual field index summarizes the visual field status as a percentage of normal age-corrected sensitivity. It is derived from the pattern deviation plot. It is center weighted. A normal field would have a VFI of around 100, and in case the patient has advanced or fields, it will be closer to 0. This can also be plotted against time to obtain a trend analysis and slope, but for this, we'll need 5 fields and over a period of 3 years. Short-term fluctuation is intra-test variability. 10 pre-selected points are thresholded twice, and the difference is the short-term fluctuation. If it is more than 3, it is unreliable or seen in advanced disease. Corrected pattern standard deviation is PSD corrected for short-term fluctuation. So what one needs to know is all these indices are interrelated and should be considered together for interpretation. Mean deviation, it helps us know the stage of glaucoma damage. Pattern deviation helps in the diagnosis of early glaucoma. In case the field defects covers the entire field, there is a reversal of the PSD. The PSD can again start coming back to the normal, that is in the low values. Zone 8 is a glaucoma hemifield test. As we all know, most of the glaucoma damage occurs in the arcuate areas across the horizontal midline. So in this, 5 sets of points are taken and they are compared. The thresholds are compared. So the report we get is outside normal limit in case the difference of sensitivities is seen less than 1 in 100. Borderline in case the difference of sensitivities is seen in less than 3 in 100. Then we have generalized depression and abnormally high sensitivity. If none of the above conditions are met, then it comes as within normal limits. Anderson's criteria helps us to know if a particular defect is glaucomatous or not. So for this, what we need is there has to be an abnormal glaucoma hemifield test. On the pattern deviation plot, 3 or more non-edge points in the 30-2 or edge points in the 24-2 with P less than 5%, 1 point with P less than 1%, and the cluster should be in the arcuate area. Abnormal PSD or CPSD with P less than 5%. How do we read a printout? So first thing is make sure all your patient information is correct. It's the right patient, right program, right stimulus size, right age. Then you come down to the reliability indices, make sure they are reliable. After that, just eyeball the grayscale. Don't read too much into it. Go to the total deviation and the pattern deviation. See what type of a defect it is. Try to correlate the defect with your indices. And then finally correlate it clinically before branding a defect as glaucomatous. So these are some of the common glaucomatous defect. We have the arcuate scotoma, which originates at the optic disc, goes around to the nasal field across fixation. This is your paracentral scotomas. This is how they look. And this is the nasal step. So now we'll just come to a few examples. So the first thing what we see is the indices. The indices look okay. There are a few depressed points in the nasal field. GST shows outside normal limit. The PSD is not being flagged. Coming to the left eye, your indices look okay. There are a few depressed points in the nasal field. GST is outside normal limits. PSD has been flagged. So accordingly, as you can see in the left eye, there is an early focus. There's an early notching in the superior neuroretinal rim. The right disc looks near normal. Again, this is the red-free photograph where you can appreciate the notch. Coming to the next example, Again, this is a patient, the right eye, the indices look okay. There are, again, depressed points in the nasal part. GSTs outside normal limits. PSD has been flagged. The left eye, your indices are okay. There's a lot of depressed points inferiorly. GST outside normal limit. PSD has been flagged again. So in this, as you can see, correspondingly, you have a superior notch, and you also have a inferior disc hemorrhage. The disc here looks maybe a very early superior thinning. So this looks something like a nasal step, and this disc looks kind of okay. But as you can see from this, typically there was an inferior defect, and here we have a superior notch. Coming to the next example, your fields are not reliable. There are a few depressed points in the nasal part. GST is within normal limits. PSD has not been flagged. Coming to the left eye, indices are okay. Depressed points in the inferior and nasal part. GST outside normal limit. PSD has been flagged. So here the right eye disc looks normal. Left eye, we can make out there's a superior thinning with a retinal nerve fiber layer defect, which is again well appreciated over here. This is another example. The indices are normal. There's a diffuse depression in the superior and inferior fields. GST is outside normal limits. PSD is also been flagged. Left eye indices look normal. Couple of depressed points in the nasal field. GST is within normal limits. PSD has not been flagged. And if you pay attention to the gaze tracking, this is what the typical skyscraper, a lot of fixation has not been proper. So as you can see in the right eye, there is a bipolar notch. There is a retinal nerve fiber layer defect. There's a superior disc hemorrhage. And here again, there is a superior disc hemorrhage. Though the field appeared to be normal, there is a disc hemorrhage. So this is why we need to clinically correlate our findings. This is another example. The indices are okay. There's depression in the nasal part of the field, like a nasal step. GST outside normal limit. PSD has been flagged. Indices look okay. Diffuse depressed points superior and inferiorly. GST outside normal limits. PSD has been flagged. And as expected, we have an advanced cup bipolar notch with a very broad wedge-shaped Rnfl defect. And here it looks okay. So this is another example. Indices look okay. You look at the difference between the total deviation and the pattern deviation. So the whole total deviation field appears depressed. On pattern deviation, the depressions appear less. Here again, the indices look normal. Grossly depressed points on the total deviation. Pattern deviation, you're seeing only few. Both of them, the GST is outside normal limits. PSD has been flagged. So as expected, the image was not, the patient has, as you can see from the image, patient has cataract. So that is why there was a difference between the total deviation and the pattern deviation. And in spite of the advanced cataract, we can make out in the right eye, there is a advanced cupping. Left eye appears to be normal. And this is my last example. The indices are not reliable, very extremely depressed, a lot of depressed points superior and inferiorly, GST outside normal limits, PSD has been flagged. Here again, the false negative is 71%. In this, it was 28%, very high. Grossly depressed fields, GST outside normal limits, PSD is also flagged. And this is the disc. So maybe a mild inferior thinning with a retinal nerve fiber layer defect. Here also we have a retinal nerve fiber layer defect with an inferior thinning. As you can see, the field does not correlate with the disc changes. Patient does have suspicious disc changes, but fields are not correlating, probably because extremely unreliable fields. So to summarize, in case we see an abnormality, first things we should, when we are analyzing a field, first figure out, are we really seeing an abnormality? And if that abnormality is consistent with glaucoma. And if it is, then these findings have to be clinically correlated before we brand a patient as having findings consistent with glaucoma. And if they have, then further fields would only be necessary to know whether the defect is stable or progressing. Thank you for your time.
Thank you, Dr. Palaniswamy, for your excellent presentation. I think we have 5 minutes left with us. Huh?
Yes, sir.
Okay. So, Lipi, a question for you. So, do you advise OCT Rnfl for all glaucoma patients or for a particular subset of patients only?
Yeah, it depends. There are 2 factors there, sir. One is that whether the patient is able to afford it or not, because the type of OCT, Zeiss or Heidelberg, their costs are a little different. And second, if it's a pre-perimetric glaucoma or the type of glaucoma, it is early glaucoma where I'm a little suspicious, then of course I'll like to have the help of OCT because GDX and HRT are sort of now gone. So we'll have optic disc ONH photograph, we'll have perimetry, visual field, 10-2 and 24-2 both, because 10-2 also shows defects in early to moderate glaucoma, and then of course OCT. So in case of pre-perimetric, early glaucomas, moderate glaucomas for progression analysis, maybe we can have a baseline OCT. So it is not particularly in severe glaucomas, I do not have to advise OCT, it's not of much use. So it's only when I'm in doubt, I go for it. Otherwise, optic nerve head photograph and perimetry is enough for me, along with the clinical picture, of course. Thank you.
You mean to say you advise in pre-perimetric glaucomas or early to moderate glaucomas only?
Yeah.
There's no point in advising in advanced glaucomas.
Yeah.
Because every time you do
for
OCT,
progression analysis, we can have.
Because in advanced glaucoma,
progression analysis, we
OCT,
can have a baseline in early and moderate.
Okay. And Dr. Palli, one question for you. So, is it advisable for to do 10-2 for every patient or for a particular group of patients only? So,
again, in case basically 10-2 is done, obviously in case you're suspecting a very advanced field loss, then you want to know whether it is there is any involvement of fixation, then you probably do the 10-2. But even otherwise, at times, in case you do a normal 24-2 or 30-2, in case you see any points near the fixation, maybe even one depressed point or things like that, it makes sense to do a 10-2. Again, in patients of NTG, it would be quite beneficial to do the 10-2 because many a times we miss out small defects in the central field, because 10-2 focuses the spacing, as I mentioned, between the points is only 2 degrees. So many a times if there's a very small defect that you have missed out, in the 30-2 or 24-2, the 10-2 will pick it up. So routinely not required, but if in case on a normal 30-2, 24-2, if you get a few depressed points, then yes, it makes sense.
Yeah, many centers in India have now routinely advising 10-2 because the separation of location is less, and so there are chances you can pick early and small defects also.
True.
So how much time we have now?
We have 3 minutes, sir.
3 minutes, okay. Just I want to summarize, especially for young ophthalmologists or the residents. It should be remembered that for the proper management of patients, we need to perform a battery of examinations and investigations, including gonioscopy, tonometry, central corneal thickness measurement, visual fields, Rnfl evaluation, and optic nerve head evaluation. In addition, the patient's detailed history, particularly the risk factors, the systemic diseases, and socioeconomic profile, All these things are very important to give a complete overview of the patient, and these will all guide us towards the proper management of glaucoma. So lastly, I would like to thank all the speakers for the wonderful presentation, and especially AIOC and Dr. Partha Biswas sir for giving us this opportunity. Okay, thank you. We can proceed with the next session.
Speakers, thank you for being a part